So today we're pleased to welcome Dr. Eileen Pitpitan, who is an associate professor in the School of Social Work at San Diego State University, and also holds an adjunct appointment as associate professor in the UC San Diego Division of Infectious Diseases and Global Public Health. She is a social psychologist and quantitative methodologist by training. Dr. Pitpitan conducts research with marginalized communities at risk for or living with HIV. One focus of her work is the use of advanced analytical techniques to examine factors underlying efficacy in HIV prevention interventions. Everyone, please welcome Dr. Pitpitan.
Thank you so much, Shayna, for the introduction. Can you all hear me okay?
Yeah.
Okay, thank you. So thanks everyone for joining for this presentation. I also want to extend my gratitude to the HIV Institute and the San Diego CFAR for inviting me to participate in this seminar series. I'm very pleased to be able to have this opportunity to present some of my research with you all today. Before I start, I do want to acknowledge my collaborators on this study, some of whom are also co-investigators on the R01 that supported this research. And as a seminar series sponsored by the HIV Institute and San Diego CFAR, I also want to acknowledge some of my previous support, including a CFAR developmental grant, as well as support provided to me as a leadership trainee for the Center's International Core. So let's start with some background. We are now 35 years into the epidemic, and we've made great strides, as you know, in HIV prevention, treatment, and care. So much so that, as you just heard, we're now talking about ending the HIV epidemic in the United States. However, in order for us to achieve that goal and end the epidemic, there remains a lot of work to be done, especially in our work with key populations and disadvantaged communities, and also in our research to address the behaviors that are required to engage these communities into HIV prevention, into the continuum of HIV prevention and care, and effectively to end the epidemic. So, if we look back at the body of research that's been done since the beginning of the epidemic, we'll find one particular area that has received a great deal of research attention. Now, for over 30 years, HIV primary prevention scientists have been developing and evaluating different behavioral interventions to prevent HIV among HIV-negative individuals. And these interventions have been developed and tested with different populations and communities, including, for example, sexual minority men, racial, ethnic minorities, and also heterosexual couples. And they've been tested in different parts of the world, of course, here in the United States, in sub-Saharan Africa, in Asia, etc. And lots of different approaches have been evaluated, whether they be brief single session counseling interventions or mHealth approaches or approaches that might involve peers, for example. So many individual studies have been done in this area that there are also dozens of systematic reviews and meta-analyses that have examined the efficacy of behavioral prevention interventions in HIV. And these are just the titles of some of the reviews that have been published. And when we look at this body of evidence, of course, there is a great deal to be learned here. We can see that some approaches work better for certain populations over others, or in different regions of the world compared to other places. But if we take sort of a meta view of this evidence, we can also see that the evidence for supporting the efficacy of these approaches is not always a clear or convincing one, particularly for biological outcomes like STI or HIV incidence, and compared to behavioral outcomes like condom use. And really, by painting this kind of muddled picture about what works and what does not, the variability and the inconsistency that's demonstrated by behavioral interventions can be viewed on the one hand as a real significant challenge to HIV prevention. And I won't deny that it sort of makes behavioral researchers like me kind of look bad. Do these approaches work or do they not? Now, while we can take this perspective, we can also think of it as a unique opportunity to also disentangle the heterogeneity of efficacy findings in HIV prevention trials. And this is a major goal of our current R01 project. So how do we tackle this? Where do we start? First, I want us to think about the traditional approach that we use to evaluating efficacy of interventions. Typically, what we do is we conduct an omnibus test that estimates an overall average effect across participants. So as depicted in this figure here, whether or not there is a total average effect of our intervention on our primary outcome, let's say. And let's say we have repeated assessments. We might do a difference in differences test in our outcome analysis. So for example, comparing the difference in HIV incidence between two study arms in their changes across time from baseline across follow-up. But even in that situation, what we're doing is still estimating a total average effect of the intervention in both arms. And this approach sometimes can mask indirect processes and variability between participants and how they're responding to the intervention. In other words, traditional outcome analyses may mask different mediating and moderating effects. In case you might need a refresher on mediation moderation, mediation is depicted here at the top to show how a third variable, our mediator variable, is explaining the effect of the intervention on the outcome. So for example, an intervention that aims to improve condom use might be effective at doing so by improving condom use self-efficacy, which in turn improves the actual behavior of condom use. And then with moderation, or another phrase for it is effect modification, the third variable moderates or changes the effect of the intervention on the outcome, either in magnitude or in direction or in both. So for example, an intervention might significantly improve condom use among older MSM, but not among younger MSM. In this example, age is a significant moderator variable. So let's focus on mediation and how it's really been applied to intervention research. Typically, mediation is only tested when there is a significant effect of X on Y, or when we see that the intervention is found to be efficacious, right? And this makes sense. We found that it works, and investigators want to unpack to examine and learn how it worked. What were the mechanisms of action? And if we look closely at the seminal paper on mediation published by Barron and Kenny in 1986, this is a step that's required to even establish mediation. You have to show there is even an effect to be mediated. However, there is growing evidence that in some situations, an intervention might appear non-significant or non-efficacious based on this traditional approach to outcome analysis, meaning there's no overall significant effect on the primary outcome. But sometimes, even in these situations, we might see mediated effects that are statistically significant, or that, in other words, that there are significant indirect pathways that might be leading to efficacy. And with this in mind, we would like to argue for, I guess, a better approach that moves beyond just thinking only about the total effect and efficacy, to also understanding mediators and moderators, even, or maybe even especially in null trials. And this approach can help us unpack and disentangle those mixed results that we find in the literature on the efficacy of behavioral HIV prevention interventions. And they have significant advantages. One is that they help inform how to pare down or ramp up interventions to really their most effective elements. So if I do a mediation analysis of my intervention and I find that the elements that really drove effects on the primary outcome were the ones that say improve self-efficacy, I would want to kind of ramp up or really focus on those elements in implementation, or pare down the elements that, that did not work well, especially thinking about the limited time and resources in clinical or community settings. And the other advantage is that with moderation analysis, we of course learn about the specific subgroups that need targeted attention that may be left behind by the intervention, for example. So ultimately, this overall approach provides us with knowledge on how to produce briefer, cheaper, and more impactful interventions. And to illustrate this with an example, I'll present some findings where we apply these methods to understanding efficacy in HPTN 015 Project Explore, or simply Explore. This is one of the most well-known HIV prevention behavioral intervention trials in our field. It was a 2-arm randomized controlled trial that evaluated the efficacy of a theory-based behavioral intervention to reduce HIV incidence among men who have sex with men across the United States, and about 4,300 MSM were enrolled. And they were followed up every 6 months to complete a survey and also an HIV test, up to 48 months or 4 years. And the primary outcome analysis of Explore found that the intervention led to an 18% lower in HIV incidence rate compared to control. However, this difference was not statistically significant. I do want to note that Explore was conducted from 1999 to 2004, so the data are over 15 years old. But I want us to focus on the methods, the bigger approach here. Although, of course, the HIV epidemiological context has changed, lots has changed since then. Really, the methods and the processes that we're evaluating here, we argue remain highly important for today's clinical trials. So our overall objective in this study was to examine mediated processes that might lead to efficacy in the Explore trial that was ruled as non-efficacious, specifically to examine potential indirect pathways leading to significant effects of the Explore intervention, and to examine whether effects of Explore on hypothesized mediators might depend on different moderators. And that will become clearer when I walk you through the actual hypothesized model and the different measures. So here, I've already mentioned some of this information about the Explore trial. MSM from 6 different cities in the US were recruited and enrolled into the trial. Additional details can be found in this paper by Koblin and colleagues, and the data are publicly available. So let's talk about now kind of what went on, how the 2 intervention arms looked. You'll see that the title of this slide, I have it as control intervention and not as control arm or control condition. And that's because the control condition itself included or consisted of an efficacious HIV risk reduction intervention. So it was twice yearly HIV pre and post-test risk reduction counseling sessions based on CDC's Project Respect. So if you look at the CDC website, it is listed as one of their effective programs, and you can request the counseling manual for the 2 sessions. So the control intervention in Explore was based on Project Respect. So these were efficacious risk reduction counseling sessions that included assessing personal risk, identifying barriers to risk reduction, and also discussions around condom use, barriers and facilitators. And then in comparison, for MSM who were randomized into the Explore intervention arm, they engaged in the same activities as those in the control arm, and also in additional HIV prevention counseling in the form of multiple intensive behavioral counseling sessions that were informed by the social cognitive theory, the theory of reasoned action, and the information, motivation, behavioral skills model, as well as other frameworks that incorporate cognitive behavioral therapy. Now, for the sake of time, I won't walk you through the details of each of these theoretical models. I'll just say that, like other health behavior theories, these theories are inherently mediation models themselves. They prescribe the elements that need to be targeted by an intervention to produce actual changes in the behavior of interest. So, for example, an intervention that is informed by social cognitive theory will want to be sure to try and improve self-efficacy around condom use, for example. Or an intervention that is informed by the theory of reasoned action might want to focus on changing perceived norms around safer sex. So the idea that if your community is doing it and your friends are engaging in or using condoms and having safe sex, then you should be more likely to as well. And then the IMB model prescribes that for individuals to improve condom use, they need to have accurate HIV knowledge, have the motivation to engage in the behavior, and also the skills to engage in the behavior. So an example of that would be to have appropriate communication skills around negotiating condoms with your sex partner. So here is kind of just a summary of the themes that were addressed by the different modules in the Explore Intervention arm. I won't say really anything about these. I'll just give you a chance to read through them so you get a sense of what was covered by these counseling sessions. So I'll walk you through now the hypothesized model and the measures. I'm going to take you through step by step in the different kind of paths in our model because it's a big model. First, we hypothesize that based on what I just mentioned about how the Explore intervention was informed by these different theories, we expect or hypothesize that the intervention would significantly change or improve, for example, safer sex self-efficacy, communication skills, and perceived norms for safer sex. So these three are your theory-based mediator variables that should explain improvements or reductions in HIV infections. And the two other variables that we measured as mediators are other variables that are more behavioral, that are also important in being associated and leading to HIV infection. So for example, engaging in alcohol or drug use before or during sex, or really high risk behavior among MSM. So in this study, for the mediator, we looked at MSM engaging in receptive anal sex without a condom with HIV positive partners or status unknown partners. And for these mediators, we use the mediators that were measured at the 6-month follow-up. So this is basically assuming that we should see effects of the intervention at almost maybe immediately and not a lot of time at first follow-up to see those changes. And then we also, remember one of our aims was to test hypothesized moderators of these A paths of the effects of the intervention on these different mediators. So why did we hypothesize that this might change the effect of the intervention on these paths? One thing that's been shown in the literature is that there's robust evidence that among MSM and other disadvantaged communities, multiple negative psychosocial conditions tend to co-occur and produce higher risk for HIV infection. This includes poor mental health, so depressive symptoms, for example. Childhood sexual abuse is robustly associated with HIV infection, as well as other types of violence, but this is the variable that we focused on in our analysis, as well as stimulant use. That is also robustly associated with HIV infection for MSM. And so the idea here is that we're hypothesizing that, for example, among men with higher depressive symptoms, we might find that the intervention did not work to improve safer sex self-efficacy, but maybe it did for men who had lower depressive symptoms. Or in a different example, maybe among men who report low amounts of stimulant use, the intervention might work to reduce condomless receptive anal sex with HIV positive or status unknown partners, but we might not see this among MSM with higher stimulant use. And then the other side of the mediation model here are B paths. We predicted that in turn, these mediators would have effects on HIV infection. And for our primary outcome, we used HIV seroconversion at any point during the 4-year follow-up. So whether or not the participant seroconverted at any point. So I'll walk you through now our measures, or the measures that were included in the EXPLORE trial. For our mediators, you can see these are some example items of the scales that were used that were shown to be reliable and valid to measure safer sex self-efficacy, communication skills, and perceived norms for safer sex. For alcohol and drug use before or during sex, participants were asked this question: since your last interview, about how often did you get high or have a few drinks immediately before or during sex? And you can see the response choices there. And then for our condom use variable, we derived this information from multiple open-ended items that asked participants in the last 6 months, did you engage in receptive or insertive anal sex with or without a condom with HIV positive partners, and then in a separate item, unknown partners. So those were asked in separate items, and then we used that information to derive this variable, to create this variable. I just want to note that if someone has a question like in the chat, I can't see it since I'm sharing my full screen. Please don't hesitate if I can clarify anything. I should have mentioned this earlier to just stop me, and I'd be happy to clarify as we move forward. Okay, so for our measures of our hypothesized moderators of the A paths, depression was measured using the CESD-10 in EXPLORE. For childhood sexual abuse, this was measured in different items that asked participants whether or not they've had a sexual experience before the age of 13 with someone who was at least 5 years or older, or having a sexual experience before the age of 17 with someone who is at least 10 years or older. And so we use the operational definition for CSA here that has been used in other studies that have focused on looking at childhood sexual abuse and EXPLORE. For stimulant use, we operationalize this in this way. So in these different items, participants were asked, in the past 6 months, how often did you use these different stimulants? And they were asked about the drugs in different questions. And we use that information to categorize participants into being reporting low stimulant use, so using never to less than once a week, or higher stimulant use, using at least 1 to 2 days and up to every day. So I want to just show you this again because I know it's a big model, and this is kind of the point in the presentation where I would typically move on from the measures to talking about the analysis plan and then the results. But in this case, since we propose some relatively complex models, it probably makes more sense for me to walk you through our model building steps. So I'm going to present some information about our sample characteristics, study retention, results from preliminary analysis, and hopefully you will see that as I walk you through this, this will lead us up to the analysis plan and the analytical approach for the final multiple mediation model that we hypothesized. So here what you're seeing is a table from a paper that was published reporting baseline data from the EXPLORE trial so that we can take a look at sample characteristics. I know that this is a big table, so let's just focus on the MSM who were enrolled into the study. You can see the age ranges here, and the 73%, so a majority of the participants were white, 15% Latino, about 7% Black. In terms of education level, a majority of the participants reported at least some college or post-college. And then the annual income looked to be normally distributed. So the mean and median kind of fell in that mid-range that you see there of 30,000 to 60,000 a year. And in terms of employment status, most of the participants, 76%, reported being employed full-time. Now let's look at baseline characteristics on the key variables that we're focusing on, our hypothesized mediator and moderator variables. I'll just say that we looked at baseline differences on these variables between the intervention and the control arm, and there were no significant differences. I just want us to highlight the prevalence of higher stimulant use, depression, and childhood sexual abuse in this study. About a quarter of the sample fell into the category of higher stimulant use. About half higher depression, which makes sense because what we did is we did a median split of the CESD-10, which is similar to, is the same as another paper that looked closely at depression in EXPLORE. And then for childhood sexual abuse, 40% were positive in that category using the measure, the operational definition used. So here is kind of the flow diagram so that you can get a sense of study retention. I know that the text is small, so I'll have you focus on what I want you to take away from this image here. And that's basically that you could see the MSM in the intervention arm on the left, and then in the control arm on the right. And overall, retention was better in the control arm compared to the intervention arm. So MSM randomized to the control arm, 92% attended the 48-month follow-up, whereas in the intervention arm, 86% attended the 48-month follow-up. And if we look at final retention status and compare people who were retained or not retained by the end of the study, we find that there was lower retention based on different sociodemographic variables. So lower retention was found among racial minority MSM, younger MSM, MSM who reported at least one female sex partner at baseline, and also MSM who reported any unprotected receptive anal intercourse at baseline. So recognizing that this might bias the results, we made sure to control for these in all of our analyses, and this mirrors the approach that was also used in the primary outcome paper. So here are, I'll present some results from our preliminary analysis. Remember that we wanted to build up to the full model. And to do that, we first tested these A paths, looking at the effect of the intervention on our hypothesized mediators measured at 6-month follow-up. And we did this using generalized linear modeling in SPSS and testing each path individually, and all were statistically significant. And then we tested the moderators of the A paths that we hypothesized in separate models. And I'll just note that depression or childhood sexual abuse did not significantly moderate any of these paths. So that regardless of depression level or experience of childhood sexual abuse, the effect of the intervention on these mediators went in the predicted direction regardless of these moderators. So the effect was uniform. However, we did find significant moderation looking at stimulant use as a moderator. So let's take a closer look at what those results look like. So this table here is summarizing the main effects and the interaction effects between the intervention arm and the stimulant use moderator variable. And what you'll see here, if we just focus on the row that's highlighted in yellow, that is showing that there was a significant interaction effect between the intervention and stimulant use on the mediator condomless receptive anal sex acts with HIV positive or status unknown partners. And there were no significant interaction effects for the other 4 mediator variables. So this was what we hypothesized, that at least some of these moderators might change the impact of the intervention on these mediators, and it did for this specific variable. And what we wanted to do, for the sake of fully understanding the data and understanding what was going on in these subgroups, is we conducted now stratified analyses to test that full big mediation model that I showed you, to see what was going on among MSM who reported low stimulant use compared to MSM who reported higher stimulant use. And to do this, we used causal mediation analysis in structural equation modeling using M+ software. So here are the results of that model among MSM with low stimulant use. You can see that the intervention significantly improved safer sex self-efficacy and safer sex communication skills. However, these variables in turn did not have any effect on HIV infection. And also, the intervention significantly reduced condomless receptive anal sex with HIV positive or status unknown partners. And as you would predict, this behavior is associated with an increased risk of HIV infection. And so what we see here is a significant A path and B path for this mediator variable of condomless receptive anal sex. And we estimated the indirect itself, and that was statistically significant. And in contrast, here are the results for MSM with higher stimulant use. You'll see that, similar to what we found among MSM with low stimulant use, the intervention significantly improved safer sex self-efficacy and communication skills. But unlike what we found with MSM with low stimulant use, in this subgroup of MSM who were engaging in higher stimulant use, we did not see that effect of the intervention on condomless receptive anal sex. Now, for descriptive purposes and to kind of shed a little bit more light into the results, I'm presenting here some frequencies of seroconversion by stimulant use. You can see that among MSM with low stimulant use, a total of 4.5% seroconverted, and then the MSM in the other subgroup, in that subgroup, a total of 11% seroconverted. So let's unpack and discuss these results. Remember that EXPLORE was ruled as non-efficacious. And the results of our current study show that EXPLORE can be effective in preventing HIV, particularly among MSM with low stimulant use. And another way that we can phrase those findings is that the intervention failed to change behavior for about a quarter of the sample, MSM with higher stimulant use. So in this subgroup, the intervention was not efficacious in preventing HIV in the way that it was efficacious among MSM with low stimulant use. And that was by significantly reducing condomless receptive anal sex with HIV positive and status unknown partners. And these results build upon the literature focusing on stimulant use among MSM Research has shown that the prevalence of past year non-medical stimulant use among MSM in the US is about 1 in 10, and that in this population, it's associated with a disproportionate burden of health harms, including HIV. So this current study builds upon this work to provide additional evidence that MSM who use stimulants require targeted prevention and intervention approaches to effectively prevent HIV and reduce other harms. And the development of such interventions have been and are currently underway. For example, work by Matthew Mimiaga is looking at the development of this type of intervention to address stimulant use as well as sexual risk behavior among MSM. Now, in addition to kind of building on that area of research, the current study also really highlights the important or imperative need for us to examine mediation and moderation in intervention trials. We argue that not just reporting the overall effect in the traditional approach that I described, but also looking at mediators and moderators. Even in trials, and maybe even especially in trials that don't demonstrate an overall effect and that are ruled as non-efficacious. You know, it's assumed that you need to show a significant effect to even examine mediation, but this is not the case, as we've demonstrated. Interventions can be shown to have significant indirect impacts on outcomes, even when an overall effect is not statistically significant. I do want us to remember or think about the results in light of their limitations. Remember that the EXPLORE data are quite old, but again, it's worth repeating that we want to focus on the value of the methods applied here, that the methods and the processes that we're evaluating are important for the field of HIV prevention and can be applied to other public health fields that are intervening on other health behavior outcomes as well. EXPLORE focused solely on MSM in the United States, so we don't know whether or not the results would generalize to other populations and regions of the world. We did only focus on stimulant use because of its robust impact on HIV-related outcomes among MSM. Focusing on other substances like alcohol or opioid use or injecting versus non-injecting might show different results or similar results in future research. And also, importantly, I want to point out that EXPLORE unfortunately did not measure or examine any socio or structural factors related to risks for HIV. Things like, dynamics or characteristics in social networks, stigma, medical mistrust, access to care. We know that in order to end the epidemic, really kind of the best intervention approaches would ideally be multi-level, targeting not only individual level psychological factors like self-efficacy, but also structural factors like stigma and access to care. And these approaches are the ones that are probably going to be more likely to yield higher effect sizes and also sustained effects on risk behavior and prevention of HIV. Just want to end with kind of final take-home message. Some of you are intervention researchers, and you know the time and the money that's needed to develop and evaluate these intervention programs. Not just the RCTs themselves, but all the work leading up to the intervention being evaluated, all of the intervention development research that needs to be conducted. And so with all of those time and resources in place, we should really take advantage to have a complete understanding of the data, have a full understanding of the data, including in non-significant and non-efficacious trials. And I'll leave you with this statement: when an intervention is ruled as non-efficacious and mediators and moderators are not examined, it might be set aside without its full potential to inform science and public health ever being realized. I'll end there. Thank you all for spending your Friday afternoon joining this presentation, and I'm happy to take any questions or comments.
Hi, Eileen, can you hear me?
Yes. Hi,
Hi,
Jackie.
hi, great presentation. I was glad that you mentioned again at the end that the data were like 15 years old, because one thing that I kept thinking about is, is this in the pre-prep, pre-U equals U era? And of course it is. And I was wondering what you might think the implications are, like transferable to sort of other prevention strategies in light of the fact that biomedical interventions are maybe more efficacious or are more efficacious than condoms at this point.
Yes, that's a really good question. And the way that I like to think about it is that in today's era of kind of a greater focus on biomedical prevention tools and treatment as prevention, I think that especially in order to end the epidemic, we really need to meet the needs of where we see disparities. So in the communities and the populations who are not accessing PrEP, who are positive and who are not in treatment or adherent to medication. And those are all behaviors that need to be addressed, right? And so you can still apply these methods to interventions that address behavior in these sort of treatment as prevention interventions as well. And also, I think that this approach, especially to understand mediators in intervention analysis, I mentioned about how to kind of use this information to know how to pare down your intervention when it comes to implementation. Let's say you find your intervention is efficacious and it's going to be implemented in a community setting with really low resources and not a lot of time on hand for people to be delivering these multiple counseling sessions. So if we can use these methods to kind of pare down the intervention to their most effective elements, then they can also be, I guess, packaged or combined with also these biomedical tools as well. So for MSM on PrEP, still making sure that they're getting psychosocial counseling to reduce risk behavior. So that's a good question. Those are my thoughts there.
Thank you.
Yeah. I did see a question in the chat. Why didn't you consider CRAI as an outcome variable since it's so closely associated with your ultimate outcome? In other words, did you examine whether the mediators in your model actually influence this variable? It would seem to me that if the interventions work, they would work via the pathway of reducing this behavior. That is a really good question, and that did come up in our analyses and in deciding on our analytic approach. And in the end, we just erred on the side of pragmatism, that we wanted to understand all of these mediators in a single step. So not looking at these kind of multiple step mediation where, for example, the intervention might have improved self-efficacy and communication skills. We did see that for both intervention arms, and then those in turn might change the behavior. It was just about kind of getting a clear picture when we were looking at all the mediators in the same model and in the same step. But it is another approach that we could have tested, and it would be worthwhile to see if we find different results kind of using that approach. Any other thoughts, questions? Shana, what do you think? Should we wrap up?
Yeah, I guess if there's no other questions.
Yes, and I'm not sure, I think this presentation will be shared or it was recorded, right? And if anyone does have questions that come up later, you saw my email addresses, and please feel free to reach out if any thoughts come or if you have more interests in learning about my research. I want to thank everyone today again for spending your late Friday afternoon listening to this presentation. And I hope everyone has a good weekend.
Thank you so much, Dr. Pitpitan.
Thank you.